5.1 Introduction. Academic counselor Dr. Mahima was discussing about various disorders with the learners. Let us look at their conversation. Dr. Mahima: hello learners. Learners: hello ma'am. Dr. Mahima: in the first block of BPCC 113, we looked at various psychological disorders. Can anyone tell me about them with their brief explanation? Seema: learner ma'am, we discussed first about schizophrenia, and it can be explained as a broad spectrum of condition that affects individuals' cognitive and emotional functioning, including delusions and hallucinations, disorganized speech, behavior and inappropriate emotions. Man-meet: learner, the other disorder that we studied was mood disorders. Mood disorders are serious changes in one's mood that may lead to distress and dysfunction. Mood disorders are classified as unipolar and bipolar disorder. Bipolar disorder was earlier known as manic depression. Janet: learner and mom, we also studied about personality disorders. In simple terms, personality disorders are a heterogeneous group of disorders and are characterized by problems in forming a stable positive sense of self and sustaining close and constructive relationships. Amir: learner, to add to what Janet explained about personality disorders. According to DSM-5, an individual is diagnosed with personality disorder if there is significant impairment in self, identity or self-direction, and interpersonal, intimacy or empathy, functioning. Seema: learner, also ma'am, DSM-5 categorizes personality disorders 3 clusters on the basis of important similarities amongst the disorders, namely cluster A, B and C. Dr. Mahima was very happy listening to all her learner. Dr. Mahima: did we miss a disorder? Seema: learner ma'am, there is also substance use disorder. Substance use disorder involves ingestion of psychoactive substances in excessive quantity. There may be a need to cut down on the usage, but the person finds it difficult to do so. In DSM-5, the substance use disorder is stated as substance-related and addictive disorders. Dr. Mahima: I am very happy that all of you have been revising and taking great interest in this course. Well, we have one more disorder to study, and that is what has been covered in the Unit 5 of BPCC 113. Seema: learner, which disorder is this ma'am? Dr. Mahima: sexual disorders and gender dysphoria. Sexual disorders can be discussed in terms of sexual dysfunction. Sexual dysfunction refers to impairment in the desire or ability to achieve sexual pleasure and gratification. As per DSM-5, gender dysphoria mainly relates to gender identity disorder. We really hope that, like the learners above, you have also been revising and learning about various disorders. In the present unit we will cover sexual disorders and gender dysphoria. Humans have sexual preferences and fantasies which may be surprising for others and even for oneself at times. Sexuality is considered to be one of the most private aspects of life, which may contribute to love, happiness and pleasure. Sex is an important concern for various people, but many have difficulty talking about it openly, as sex is considered as a taboo in various societies and cultures. Thus, in the present unit, we will attempt to define boundaries between normality and psychopathology in understanding sexuality. We will also describe the influence of culture and gender on sexual norms. We will explain sexual response cycle of men and women. Sexual dysfunctions and paraphilias will also be explained. We will finally try to develop an understanding of the treatment approaches of sexual disorders and dysfunctions. Box 5.1. Some important terms to remember: sex. Sex, quality of being male or female. Sexual intercourse, insertion of penis when erect in vagina. Other forms include anal sex, penetration of the anus by the penis, oral sex, penetration of the mouth by the penis or oral penetration of the female genitalia, and fingering, sexual penetration by the fingers. Sexuality encompasses sex, gender identities, roles, sexual orientation, pleasure, intimacy and reproduction. Sexual health, the integration of somatic, emotional, intellectual and social aspects of sexual being in ways that are positively enriching and enhance personality, communication and love. Sexual rights, rights free of coercion, discrimination and violence. Sexual norm, it could be a personal or social norm. Culture having a norm regarding sexuality and defining it on the basis of age, consanguinity, race. 5.2 What is normal sexuality? Definition of normal or desirable human sexual behavior may vary with time and place. For instance, von Kraftebing claimed that early masturbation would damage the sexual organs and would lead to the exhaustion of a finite reservoir of sexual energy. Victorian view was that too much sexual activity and sexual appetite was dangerous and thus had to be restrained using various ways. Current views seem to be very tolerant of a variety of sexual expressions. It is only when these fantasies begin to affect other people and harm them, they begin to qualify as abnormal. If the sexual fulfillment becomes difficult or socially unacceptable, then that would be considered as abnormal. 3 kinds of sexual behavior meet this definition. First, gender identity disorder, psychological dissatisfaction with the biological sex of himself/herself. This disorder may not be specifically sexual in nature, rather a disturbance in the person's identity as either a male or female, the traditional binary distinction. Second, difficulties in functioning adequately while having sex are categorized under various sexual dysfunctions. And, third, is a category named paraphilias, a term for sexual deviation. It includes deviances in which sexual arousal occurs in the context of inappropriate objects or individual. But, before understanding these disorders, it is important to revisit the question: what qualifies as normal sexual behavior? One way to understand normality has been to understand the norm or what is prevalent in the society, although it may not be necessarily the most correct or accurate way to go about it. In a survey conducted by Billy, Tanfer, Grady and Kleppinger, 3,321 males were interviewed, in the age bracket of 20 to 39 in United States. All participants in the study were sexually experienced, at least in the vaginal intercourse. 3/4 participants in the study were engaged in oral sex, but only 1/5 had ever participated in anal sex. Another finding of the research was that almost 23.3% of the sample had sex with 20 or more partners, which is considered as the high-risk behavior. More than 70% were found to have only one sexual partner during the previous year. One of the surprising findings from this research was that majority of the men had engaged only in heterosexual behavior and only 2.3% had engaged in both homosexual as well as heterosexual behavior, whereas only 1.1% had engaged in homosexual behavior exclusively. 5.3 Sexual response cycle. Many researchers have tried understanding the sexual response cycle, but the Kinsey Group, in 1940s, made a breakthrough attempt by interviewing people about their sexuality. Kinsey, Pomeroy, and Martin, 1948. Masters and Johnson went a step ahead by collecting laboratory data in order to study physiology and psychology of sexual behavior. They have contributed 2 major books to the field: Human Sexual Responses and Human Sexual Inadequacy. Phases in Human Sexual Response Cycle. 1. Desire phase. Sexual urges occur as a response to the sexual cues or fantasies. 2. Arousal phase. This stage is like the preparation for main event and involves foreplay as well. An increase in muscular tension, breathing and heart rate can be noticed. In males, penile tumescence, increased flow of blood into penis, and erection can be observed. In females, vasocongestion, blood pools in the pelvic region, can be observed leading to vaginal lubrication and breast tumescence, erect nipples. 3. Plateau phase. In this stage, the changes noticed in the arousal phase are intensified. Genitalia may become highly sensitive, may be painful to touch. Muscle spasm can be noticed in the feet, hands and face. 4. Orgasm phase. This is the climax of the sexual response cycle that involves involuntary muscle contraction. There is rapid intake of oxygen followed by sudden, forceful release of sexual tension. In males, there is feeling of inevitability of ejaculation followed by ejaculation of semen, and in females, rhythmic contractions in vagina occurs. 5. Resolution phase. This stage is marked by decrease in arousal followed by orgasm, especially in males. It is marked by a general sense of well-being, enhanced intimacy and fatigue. With further sexual stimulation, females are capable of returning to orgasm phase, multiple orgasms in females, but males need more time to recover after the orgasm, and this period is known as the refractory period, which may last from several minutes to hours. 5.4 Sexual disorders. Sexual disorders can be discussed in terms of sexual dysfunction. Sexual dysfunction refers to impairment in the desire or ability to achieve sexual pleasure and gratification. It can mainly be divided in 3 categories, as proposed by DSM-5: those involving sexual desire and arousal, orgasmic disorders and sexual pain disorders. Separate diagnostic criteria have been provided for both men and women. Sexual dysfunction may occur in both homosexual and heterosexual couples. It can be due to psychological or interpersonal reasons, or may have physical factors involved behind it. It is also important to note that they might be a secondary consequence to certain medications people may be taking. For sexual dysfunctions to be diagnosed, it is important that the dysfunction should be persistent and recurrent and should result in marked clinical distress with functioning. 5.4.1 Male hypoactive sexual desire disorder. A person diagnosed with hypoactive sexual desire disorder has little or no interest in any sexual activity and has been distressed due to low levels of sexual thoughts and desires for at least 6 months. There are other ways to gauge it. If the frequency of sexual activity is less than twice a month for a married couple, or if they do not think about sex at all. There are men who may have sex twice a week but just to keep their marriage safe, and in reality, do not think about sex at all. It is important to understand the possible factors that may be behind it before the diagnosis is given. It could be due to some problems emanating from partners, due to some cultural beliefs, or even personal vulnerabilities or a medical condition. Many experts have a belief that it is usually acquired or situational rather than lifelong. Treatment. It has been found that psychological factors are perhaps more closely linked to low sexual desire in men in comparison to hormonal factors. Thus, psychological treatment and therapies are more effective. For men with low testosterone levels, testosterone injections are used. But still more research is required to understand the probable treatment procedures of this disorder. Box 4.2 DSM-5 Criteria for male hypoactive sexual desire disorder. A persistently or recurrently deficient, or absent, sexual / erotic thoughts or fantasies and desire for sexual activity. The judgment of deficiency is made by the clinician, taking into account factors that affect sexual functioning, such as age and general and socio-cultural contexts of the individual's life. B. The symptoms in criterion have persisted for a minimum duration of approximately 6 months. C. The symptoms in criterion cause clinically significant distress in the individual. D. The sexual dysfunction is not better explained by a non-sexual mental disorder or as a consequence of severe relationship distress or other significant stresses and is not attributable to these effects of a substance/medication or another medical condition. 5.4.2 Erectile disorder. Erectile disorder is a sexual arousal disorder. Here, the issue is not sexual desire. Individuals with arousal disorder may have sexual urges and a strong desire to have sex, but the problem is in becoming physically aroused. A male with an inability to achieve or maintain erection sufficient enough for sexual intercourse is diagnosed with the erectile disorder. It is diagnosed only when the difficulty has a psychogenic origin, for a combination of psychogenic and medical factors are involved. Masters and Johnson hypothesized that anxiety about sexual performance can lead to erectile dysfunction. Later, Barlow and colleagues have questioned the role of anxiety, as anxiety can also enhance sexual performance. Barlow highlighted that the cognitive distractions associated with anxiety in dysfunctional men may interfere with sexual arousal. They may also get distracted by negative thoughts about their performance during a previous sexual encounter. Thus, their distraction and preoccupation with negative thoughts than anxiety has a role to play here in inhibiting their sexual arousal and further feeding on the self-defeating thoughts due to the inability to achieve erection. For majority of men who take antidepressant medicines, SSRIs, erectile dysfunction could be a side effect. Increase in age can also lead to erectile difficulties. Most of the cases of erectile dysfunction in older men can be due to vascular diseases, due to which the ability of the penis to hold blood decreases to maintain an erection. Thus, hardening of the arteries, high blood pressure, and other diseases such as diabetes that cause vascular problems often account for erectile disorder. Smoking, obesity, and alcohol abuse are associated lifestyle factors, and lifestyle changes can improve erectile function. Treatment. A number of medical treatment techniques are employed in this case, especially when cognitive behavioral techniques fail. These treatment techniques include 1. Medicines to promote erection, Viagra, Levitra, Cialis. 2. Injections of smooth muscle relaxing drugs onto erection chambers. 3. A vacuum pump. In cases of nerve damage and thus inability to achieve erection, penile implants are used. These are the devices made of silicone rubber which can be inflated to provide erection on demand. The commercial success of drugs like Viagra and Cialis is indicative of the prevalence of sexual dysfunction in men and also the high importance people give to sexual performance. Studies also reveal that if these medicines are used in conjunction with cognitive behavioral therapy, their effects can be enhanced. Box 5.3, DSM-5 Criteria for Erectile Disorder. At least one of the three following symptoms must be experienced on almost all or all, approximately 75–100%, occasions of sexual activity, in identified situational contexts or, if generalized, in all contexts. 1. Marked difficulty in obtaining an erection during sexual activity. 2. Marked difficulty in maintaining an erection until the completion of sexual activity. 3. Marked decrease in erectile rigidity. B. The symptoms in criterion have persisted for a minimum duration of approximately 6 months. C. The symptoms in criterion cause clinically significant distress in the individual. D. The sexual dysfunction is not better explained by a non-sexual mental disorder or as a consequence of severe relationship distress or other significant stresses and is not attributable to the effects of a substance/medication or another medical condition. 5.4.3 Premature, early, ejaculation disorder. Premature ejaculation of DSM-4TR is called as early ejaculation disorder in DSM-5. Ejaculation may occur before, on, or very shortly after penetration, much before the man wants it to. Studies have revealed that the average duration of time to ejaculate with this disorder is almost 15 seconds. Very importantly, the major consequence of this disorder is failure of the partner to achieve sexual satisfaction and also embarrassment for the early ejaculating man. Due to early ejaculation, both the sexual and interpersonal relationship of the individual with their partner gets impacted negatively. As per DSM-5, a number of factors might impact the time of ejaculation, but the key element to diagnosis is if the ejaculation occurs before, on, or just after penetration, and that too before the man wants it, then the individual may be diagnosed with early ejaculation disorder. This is because, in sexually normal men, the ejaculatory impulse is under voluntary control, at least to some extent. They can forestall ejaculation from penetration to almost 10 minutes. Men with early ejaculation are unable to do so effectively. There can be a variety of factors working behind it, such as higher anxiety levels, high penile sensitivity, or high levels of arousal to sexual stimuli. Yet, the explanation remains insufficient to understand the reasons behind early ejaculation. Treatment. Behavioral therapy has been used a lot to deal with the issue of early ejaculation, especially the technique of pause and squeeze as developed by Masters and Johnson. But, some recent studies have reported lower success rate of the technique. It has been found that the antidepressants such as paroxetine, sertraline, fluoxetine and dapaxetine are helpful in prolonging ejaculation as it blocks the serotonin reuptake. Box 5.4, DSM-5 Criteria for Premature, Early, Ejaculation Disorder. A persistent or recurrent pattern of ejaculation occurring during partnered sexual activity within approximately 1 minute following vaginal penetration and before the individual wishes it. Note, although the diagnosis of premature, early, ejaculation may be applied to individuals engaged in non-vaginal sexual activities, specific duration criteria have not been established for these activities. The symptom in criterion must have been present for at least 6 months and must be experienced on almost all or all, approximately 75–100%, occasions of sexual activity, in identified situational contexts or, if generalized, in all contexts. See the symptom in criterion causes clinically significant distress in the individual. The sexual dysfunction is not better explained by a non-sexual mental disorder or as a consequence of severe relationship distress or other significant stresses and is not attributable to the effects of a substance/medication or another medical condition. 5.4.4 Delayed ejaculation disorder. It refers to the inability to ejaculate during intercourse in men. Men with total inability to ejaculate are rare, and about 85% of men who have delayed ejaculation disorder can achieve orgasm by getting stimulation in other ways, mainly during solitary masturbation. In some other cases, men can ejaculate in front of the partner but only through manual or oral stimulation. Delayed ejaculation can also be due to physical issues such as multiple sclerosis or use of some antidepressants. Treatment: couple therapy in which man tries to achieve orgasms through intercourse with a partner has found to be effective. It is important to reduce the performance anxiety about achieving the orgasm versus sexual gratification and intimacy. This is also done using behavioral therapy and cognitive behavioral therapy approaches. Box 5.5, DSM-5 Criteria for Delayed Ejaculation Disorder. Either of the following symptoms must be experienced on almost all or all occasions: approximately 75–100% of partnered sexual activity, in identified situational contexts or, if generalized, in all contexts, and without the individual desiring delay. 1. Marked delay in ejaculation. 2. Marked infrequency or absence of ejaculation. B. The symptoms in criterion A have persisted for a minimum duration of approximately 6 months. C. The symptoms in criterion A cause clinically significant distress in the individual. D. The sexual dysfunction is not better explained by a non-sexual mental disorder or as a consequence of severe relationship distress or other significant stresses and is not attributable to the effects of a substance/medication or another medical condition. 5.4.5 Female sexual interest/arousal disorder. As per the research, women who have low sexual desire also have lower levels of arousal during sexual activity and thus, for women, DSM-5 has combined the category of interest and arousal in the disorder, female sexual interest/arousal disorder. Psychological factors have an important role to play in reduced sex drive. There is one slight issue with the diagnosis of this disorder. People usually come to get themselves treated on the behest of their partners and also due to readily available public knowledge on their own owing to their understanding of frequency of sexual contact. It is important to know that frequency of sexual contact vary widely among normal individuals, therefore, it becomes difficult to decide what is not enough and would require clinical intervention. DSM-5 leaves this judgment to the clinician on the basis of patient's age and life context. If a person has depression or had it in the past, that could also contribute to sexual desire disorder. Testosterone may also have a role to play in diminishing sexual desire, but testosterone replacement therapy is beneficial, both in men and women, only in the cases of people with very low testosterone. Daily hassles, worries, poor relationship and lesser satisfaction, conflicts and disagreements, weak or reducing emotional bonding may also contribute to sexual desire disorder. Until recently, female sexual desire and the disorders related to it was not given a lot of importance. This could have been due to sweeping mindset and a myth that women do not care much about sex. But recently, some findings have suggested that a linear progression from desire to arousal and finally orgasm, as originally posited, might not be there always in the case of women. For many women, sexual desire is experienced only after sexual stimuli has led to subjective sexual arousal. For some, sexual activity may act as a motivator to enhance emotional intimacy or self-image as an attractive woman. Major manifestation of sexual arousal disorder is failure to achieve the swelling and lubrication of the vulva and vaginal tissues, making sexual intercourse difficult and uncomfortable. The cause is not being researched upon very well, but it could range from sexual traumatization at an early stage to the twisted and taboo views of the society about sex. It could also be due to disinterest in the current, some sort of medical illness, diabetes, some injury, etc., and reduced levels of estrogen, especially during menopause. Treatment. No effective aphrodisiacs exist as such to help in enhancing sexual desire. As mentioned earlier, injecting testosterone works with men and women who have very low testosterone levels. Some studies have highlighted that continuous use of bupropion, antidepressant, may improve sexual arousal and orgasm frequency in women with hypoactive sexual desire disorder. Very much like other sexual dysfunctions, patients are taught some sensate focus exercises involving couples to learn to focus on pleasurable sensations by touching without making intercourse or achieving orgasm as a major goal. Box 5.6, DSM-5 Criteria for Female Sexual Interest/arousal Disorder. A lack of, or significantly reduced, sexual interest / arousal, as manifested by at least 3 of the following: 1. Absent / reduced interest in sexual activity. 2. Absent / reduced sexual / erotic thoughts or fantasies. 3. No / reduced initiation of sexual activity, and typically unreceptive to a partner's attempts to initiate. 4. Absent / reduced sexual excitement / pleasure during sexual activity in almost all or all, approximately 75–100%, sexual encounters, in identified situational contexts or, if generalized, in all contexts. 5. Absent / reduced sexual interest / arousal in response to any internal or external sexual / erotic cues, for example, written, verbal, visual. 6. Absent / reduced genital or non-genital sensations during sexual activity in almost all or all, approximately 75–100%, sexual encounters, in identified situational contexts or, if generalized, in all contexts. B. The symptoms in criterion have persisted for a minimum duration of approximately 6 months. C. The symptoms in criterion cause clinically significant distress in the individual. D. The sexual dysfunction is not better explained by a non-sexual mental disorder or as a consequence of severe relationship distress, for example, partner violence, or other significant stressors, and is not attributable to the effects of a substance / medication or another medical condition. 5.4.6 Genitopelvic pain / penetration disorder. DSM-4 had mentioned 2 sexual pain disorders, vaginismus and dyspareunia, which have been combined in DSM-5 because of lack of scientific report to support distinct categories. Vaginismus was understood to be an involuntary spasm of the muscles near the vaginal entrance, thus preventing penetration and sexual intercourse. But these vaginal spasms could not be reliably diagnosed, and women who were diagnosed with vaginismus basically complained of pain during penetration and anxiety before and during sexual intercourse. Confusion over difference between the two is over the fact that the hallmark symptom of vaginismus does not occur clearly, whereas the chief symptom of dyspareunia, genital pain associated with sexual intercourse encounters, is common in women with vaginismus as well. Thus, in DSM-5 both have been combined together. Studies have revealed that genitopelvic pain disorder has more of a biological basis than psychological. It could occur due to infections or inflammation of vagina, vaginal atrophy that may occur with age, scars and bruises from vaginal tearing, or lack of sexual arousal. Some researchers have argued against categorizing sexual pain disorders as sexual disorders, as the pain caused here is qualitatively similar to the pain in other areas of the body, and even the cause of pain is similar to other pain disorders. Thus, they have argued to categorize these as pain disorders. Treatment: cognitive behavioral interventions including education about sexuality, cognitive restructuring, progressive muscular relaxation and vaginal dilation exercises have been found to be effective in sexual pain disorders. Some medical treatments such as surgical removal of the vulvar vestibule has been found to be successful. Box 5.7. DSM-5 criteria for genitopelvic pain / penetration disorder. A genitopelvic pain / penetration disorder is defined as persistent or recurrent difficulties with one or more of the following: 1. Vaginal penetration during intercourse. 2. Vulvovaginal or pelvic pain during vaginal intercourse or attempts at penetration. 3. Fear or anxiety about vulvovaginal or pelvic pain in anticipation of, during, or as a result of vaginal penetration. 4. Tightening or tensing of the pelvic floor muscles during attempted vaginal penetration. In order to meet the diagnostic criteria, at least one of the above-mentioned symptoms must have persisted for at least 6 months and must cause significant distress. The disorder can be specified by severity and as either lifetime or acquired. 5.4.7 Female orgasmic disorder. Female orgasmic disorder can be diagnosed in women who have no issues pertaining to sexual arousal or otherwise enjoying sexual activity but show recurrent delay or absence of orgasm after the excitement phase, as per DSM-5. They would also be distressed by this. Achieving orgasm through clitoral stimulation during sexual intercourse is such a common occurrence and thus is not regarded as a dysfunction. However, there is a small percentage of women who can achieve orgasm only through direct mechanical stimulation of clitoris, oral stimulation or through electric vibrators. And there are some who are unable to achieve orgasm under any sort of stimulation, called as lifelong orgasmic dysfunction. The diagnosis of orgasmic dysfunction in women has always been complicated due to the subjective quality of orgasm, as it varies from one woman to another or within the same woman from time to time. There can be various contributory factors towards female orgasmic disorder such as feeling fearful about the sexual relationship, feeling of inadequacy, anxiety and tension. Some women also tend to experience sexual guilt. Some other try to pretend having an orgasm or fake orgasms. This may leave them irritated and frustrated with themselves and eventually their partners as well. Yet, researchers have not been able to identify the cause with certainty. Possible biological factors responsible here could be intake of SSRIs. Some recent evidences have suggested that the genital anatomy of women and the differences in it, from one to another, may allow some to achieve orgasm more easily than others. Treatment. There has always been questions if treatment should be sought for orgasmic disorder, especially in women, and clinicians have come to agree that the decision should be best left to women themselves about it. But, in cases with lifelong orgasmic disorder it is best to seek treatment. Cognitive behavioral treatment involves education about anatomy, sexuality and masturbation exercises. Gradually the partner is involved in helping to attain orgasm. It is important to note here that situational anorgasmia may have psychological and relationship-related issues involved and are more difficult to treat. Box 5.8, DSM-5 Criteria for Female Orgasmic Disorder. A presence of either of the following symptoms and experienced on almost all or all, approximately 75–100%, occasions of sexual activity, in identified situational contexts or, if generalized, in all contexts. 1. Marked delay in, marked infrequency of, or absence of orgasm. 2. Markedly reduced intensity of orgasmic sensations. B. The symptoms in criterion have persisted for a minimum duration of approximately 6 months. C. The symptoms in criterion cause clinically significant distress in the individual. D. The sexual dysfunction is not better explained by a non-sexual mental disorder or as a consequence of severe relationship distress, for example, partner violence, or other significant stressors and is not attributable to the effects of a substance/medication or another medical condition. 5.5 Gender dysphoria. The essence of masculinity and femininity is a deep-seated personal sense and has been termed as gender identity, which is different from gender roles. Gender roles are about the masculinity and femininity of overt behavior. Although gender identity has a strong correlation with the biological sex, but the correlation is not perfect. Some people feel as if they are trapped in a body of wrong sex, that is, their physical gender is not consistent with their sense of identity. As per DSM-5, gender identity disorder is termed as gender dysphoria. It is the discomfort one has with one's sex-based physical characteristics or with one's societally assigned gender. The change has been made to make the diagnosis more descriptive and theoretically as neutral as possible. So, people who were diagnosed with gender identity disorder, GID, earlier will certainly experience gender dysphoria. It has been taken into consideration that the degree of dysphoria may vary or fluctuate over a period of time within the same individual. Gender dysphoria can be diagnosed either during adolescence or adulthood or even at the childhood stage. DSM-5 criteria for gender dysphoria in adolescents and adults is as follows: a marked incongruence between one's experienced /expressed gender and assigned gender, of at least 6 months duration, as manifested by at least two of the following: 1. A marked incongruence between one's experienced /expressed gender and primary and / or secondary sex characteristics, or in young adolescents, the anticipated secondary sex characteristics. 2. A strong desire to be rid of one's primary and / or secondary sex characteristics because of a marked incongruence with one's experienced / expressed gender, or in young adolescents, a desire to prevent the development of the anticipated secondary sex characteristics. 3. A strong desire for the primary and / or secondary sex characteristics of the other gender. 4. A strong desire to be of the other gender, or some alternative gender different from one's assigned gender. 5. A strong desire to be treated as the other gender, or some alternative gender different from one's assigned gender. 6. A strong conviction that one has the typical feelings and reactions of the other gender, or some alternative gender different from one's assigned gender. B. The condition is associated with clinically significant distress or impairment in social, occupational, or other important areas of functioning. 5.5.1 Gender dysphoria in childhood. Boys who have gender dysphoria usually show a marked preoccupation with the activities which are typically and traditionally defined as feminine. They prefer to dress like girls and enjoy activities and games like playing with dolls or playing house. While playing house, they most often become a mother. They usually avoid rough play behavior and express their desire to be a girl. They may like watching shows with their favorite woman character. They are often laughed upon, called as sissies by their friends. Girls with gender dysphoria usually recoil or become hesitant at their parents' attempt to dress them up in traditional feminine clothes. They prefer short hair and fantasize typically powerful heroes like Iron Man, Superman, etc. They show lesser interest in playing with dolls and rather are interested in other sports. They look like what we call as tomboys but differ from them due to their desire to be a boy or grow up as a man. They are often misidentified by strangers as boys. Usually girls with gender dysphoria are treated better in comparison to boys with gender dysphoria. It is interesting to note that most common adult outcome of boys with gender dysphoria is homosexuality rather than transsexualism, opting for surgeries for sex change. Researchers over the years have argued that such children should not be considered disordered as they might be unhappy due to the societal pressure and bias of negative attitude towards cross-gender behavior. But some others have concluded it to be due to the discrepancy between their biological sex and psychological gender and are called as with mental disorder. Also, they are laughed upon and mistreated by their peers, have tensed relationships with their parents leading to their distress eventually. It is again important to note here that some cultures, like Samoa, do not show stigma towards gender non-conforming children. DSM-5 criteria for gender dysphoria in children. DSM criteria for gender dysphoria in children is as follows: a marked incongruence between one's experienced / expressed gender and assigned gender, of at least 6 months duration, as manifested by at least 6 of the following: one of which must be criterion a 1-1, a strong desire to be of the other gender or an insistence that one is the other gender, or some alternative gender different from one's assigned gender. 2. In boys, assigned gender, a strong preference for cross-dressing or simulating female attire, or in girls, assigned gender, a strong preference for wearing only typical masculine clothing and a strong resistance to the wearing of typical feminine clothing. 3. A strong preference for cross-gender roles in make-believe play or fantasy play. 4. A strong preference for the toys, games, or activities stereotypically used or engaged in by the other gender. 5. A strong preference for playmates of the other gender. 6. In boys, assigned gender, a strong rejection of typically masculine toys, games, and activities and a strong avoidance of rough and tumble play, or in girls, assigned gender, a strong rejection of typically feminine toys, games, and activities. 7. A strong dislike of one's sexual anatomy. 8. A strong desire for the primary and forward/or secondary sex characteristics that match one's experienced gender. B. The condition is associated with clinically significant distress or impairment in social, school, or other important areas of functioning. Treatment. For children and adolescents with gender dysphoria, the attempt is to mainly deal with child's unhappiness with the biological sex and to ease the relationship with the parents. They may also have mood and anxiety-related issues that may need therapeutic attention. To treat gender dysphoria, psychodynamic perspective has been found to be helpful. Herein the inner conflicts are examined, understood and resolved. 2 important facts to note about gender dysphoria are, first, for most children with gender dysphoria, the problem remits during childhood only. Second, children who remain with dysphoria till their adolescence may remain so even in their adulthood and may opt for sex reassignment surgeries. 5.5.2 Transsexualism. Adults with gender dysphoria may have a desire to change their sex permanently and transit to the gender with which they identify. It is called as transsexualism. This is usually done by seeking medical assistance. It is perhaps a rare disorder, as some of the past European researches have suggested that about 1 in 30,000 males and 1 in 100,000 females seek this sex reassignment surgery. But some recent studies have suggested that approximately 1 in 12,000 men in Western countries opt for it. It is important to note that many transsexuals had gender dysphoria as children, but most children who have gender dysphoria do not opt for sex reassignment surgeries. Most of the female-to-male transsexuals recall being tomboyish as children, and most of them are sexually attracted to women. But, in the case of male-to-female transsexuals, there can be 2 kinds of homosexual and autogenephilic transsexuals. Homosexual transsexuals are very much like gay men with same-sex orientation. So, they are attracted to males, which is their biological sex before the surgery. But, because they identify themselves as women, they often define their sexual orientation as heterosexual. For autogenephilic transsexuals, they are attracted to thoughts, images or fantasies of themselves as women. Attempts have been made to understand transsexualism. One of the hypotheses in this regard says that there could be some prenatal hormonal influences due to which children with gender identity disorder may later become transsexuals. There is also a possibility that some families are more in support of their boys' defeminization as compared to others. It is also important to highlight that they are different from people with transvestic fetishism, as their purpose of cross-dressing is not sexual arousal or gratification. Here, the goal is to live life in a manner that is consistent with that of the gender they prefer to be. They must also be distinguished from intersex individuals, as they are not born with ambiguous genitalia or associated with any hormonal or physical abnormalities. It has been agreed upon that usually psychotherapy is not very effective with adolescents or adults with gender dysphoria. However, surgical sex reassignment has been found to be effective. Biological men are given estrogen for breast development, skin softening, etc., and biological women are given testosterone to increase facial and bodily hair, deepen the voice and cease menstruation. Living with hormonal therapy serves as a trial period for them before undergoing surgery. Only a small section of female-to-male transsexuals seek an artificial penis, as the surgery is quite expensive and also not very well developed. Another important point to consider here is that the artificial penis is not capable of erection, and thus they must always rely on artificial ways to have intercourse. Thus, many also function sexually without penis. Box 5.9. Paraphilic disorder. Paraphilias are recurrent, intense sexually arousing fantasies, urges and behavior that involve a. Non-human objects, shoes, hair, etc. b. Suffering or humiliation of oneself or partner, c. Children or other non-consenting people. It is to be diagnosed if the condition lasts at least for 6 months. Here, there is deviation, para, in something that the individual is attracted to, philia. Diagnosing paraphilias have always remained challenging due to a few reasons. With some paraphilias, the individual, having the paraphilia, does not experience distress in himself/herself. For instance, a pedophile who has assaulted and molested child does not feel guilty about it. However, it has been considered as a mental disorder due to its impact on others, especially the child. Another important aspect here is the fact that there are some categories of paraphilias which are also compatible with psychological health and happiness and may neither have signs of distress and may also involve two consenting adults. For instance, someone with a foot fetish may find a partner comfortable with this sexual interest and may readily indulge in it, while some others may experience shame and guilt in expressing such a desire. Thus, paraphilias are unusual sexual interests, not causing harm to the individual or others. It is only if they cause harm, they are considered as paraphilic disorders. With time, some of these behaviors are also becoming more common, raging a debate if it is appropriate to diagnose some of these behaviors as paraphilic disorders. Fetishistic disorder, sexual sadism and transvestic disorders have not been included in the classification system of the Swedish National Board of Health and Welfare, stating reasons that people practice variants of sexual behavior safely and with consenting adult partners, thus, not to be diagnosed. Paraphilias have a compulsive quality to themselves, and as per research, some individuals require orgasmic release as often as 5 to 10 times a day. Fetishistic disorder. The fetishistic disorder is marked by recurrent, intense sexually arousing fantasies, urges and behaviors that involve the use of some inanimate object or part of the body to obtain sexual gratification. Clothing, especially undergarments, leather, garter belts, etc., and articles related to feet, women's shoes, stockings, are considered to be common fetishes. Apart from this, some people focus on certain non-sexual parts of the body such as nails, feet, hands, hair, etc. for arousal. According to DSM-5, it is characterized as a condition with persistent use of or dependence on non-living objects or specific focus on a body part, non-genital, for sexual arousal. In the earlier versions of DSM, arousal revolving around non-genital body parts was called as partialism. DSM-5 included partialism into fetishistic disorder. Majority of the reported cases of fetishism are of males. Female fetishists are extremely rare. Some continue their fetish by themselves in secrecy by kissing, smelling, sucking, fondling or just gazing at the object of interest while masturbating. Others ask their partners to put on the fetish as a stimulant for intercourse. The attraction for a fetishist may seem involuntary and irresistible, compulsive in nature. The disorder may begin in adolescence, although it may acquire its special significance even earlier than this, that is, during childhood. In order to obtain the required object of arousal, some men may even commit theft, burglary or assault. It has been seen that articles that are most commonly stolen by them are women's undergarments. One common hypothesis regarding causality of fetishism focuses on classical conditioning and social learning theories. For example, female undergarment is closely linked to the act of sex and the female body thus becoming an object of arousal. The person with fetishistic disorder feel compulsively attracted towards the object of interest. The attraction is experienced as involuntary and irresistible. The degree of erotic focus is what distinguishes fetishistic disorder from an ordinary attraction. DSM-5 criteria for fetishistic disorder. Over a period of at least 6 months, recurrent and intense sexual arousal from either the use of non-living objects or a highly specific focus on non-genital body part, as manifested by fantasies, urges, or behaviors. B. The fantasies, sexual urges, or behaviors cause clinically significant distress or impairment in social, occupational, or other important areas of functioning. C. The fetish objects are not limited to articles of clothing used in cross-dressing, as in transvestic disorder, or devices specifically designed for the purpose of tactile genital stimulation, for example, vibrator. DSM-5 criteria for transvestic disorder. Over a period of at least 6 months, recurrent and intense sexual arousal from cross-dressing, as manifested by fantasies, urges, or behaviors. B. The fantasies, sexual urges, or behaviors cause clinically significant distress or impairment in social, occupational, or other important areas of functioning. Voyeuristic disorder. A young, married man lived in an attic apartment with his wife. The wife went out to work in order to enable her husband to attend his school and run the household. She would usually come home late at night tired and irritable and often in no mood for indulging in sexual activity. They also mentioned that the dammed springs in the bed would squeak, perhaps further dampening her spirits. In order to obtain some sexual gratification, he would try to look through his binoculars at the room next door and would see the young couple there engaged in erotic activities occasionally. As this would stimulate him highly, he continued with this activity. During his second endeavor, he was reported to the police. This offender was found to be immature for his age, moralistic in his attitude towards masturbation and sex, and prone to engage in rich but immature sexual fantasies. According to DSM-5, voyeuristic disorder involves a recurrent and intense desire to obtain sexual arousal and gratification by watching others in a state of undress, especially women, or couples engaging in sexual activity. Such individuals usually masturbate during their peeping activity and achieve orgasm either while watching the activity or while remembering the peeping activity. They are commonly called as peeping Tom, mostly men. For some men with this disorder, voyeurism is the only sexual activity they indulge in. For others, it might be a preferred one but not absolutely necessary for sexual arousal. A true voyeur is not excited by watching a woman who is undressing for his benefit. It is the element of risk that is important for the voyeur, and the anticipation of the reaction of women once she would get to know about him watching her. People with this disorder are mostly charged with loitering than with peeping. Voyeurism commonly occurs with other paraphilias such as exhibitionism. DSM-5 criteria for voyeuristic disorder. Over a period of at least 6 months, recurrent and intense sexual arousal from observing an unsuspecting person who is naked, in the process of disrobing, or engaging in sexual activity, as manifested by fantasies, urges, or behaviors. B. The individual has acted on these sexual urges with a non-consenting person, or the sexual urges or fantasies cause clinically significant distress or impairment in social, occupational, or other important areas of functioning. C. The individual experiencing the arousal and or acting on the urges is at least 18 years of age. Exhibitionistic disorder. It is a recurrent and intense urge, fantasy or behavior to obtain sexual gratification by exposing one's genitals to others, usually unwilling strangers, without their consent and in inappropriate circumstances. Very much like voyeuristic disorder, there is rarely an attempt to have an actual contact with the stranger. In some cases, the exposure of genitals is also accompanied by suggestive, vulgar gestures or even masturbation. The exposure may take place in any secluded location or sometimes even in certain public spaces. It has been understood that the element of shock is highly arousing to these individuals. In many instances, the exposure is repeated under constant sort of conditions. For instance, the offender may exhibit himself at the same place or at the same time of the day every time. For male offenders, in most cases the victim is usually a young or middle-aged woman who is unknown, stranger, to the offender. Children and adolescents could also be a target of the offenders. Exhibitionism is commonly seen to co-occur with voyeurism, sadomasochistic interest and cross-dressing. It is mainly the intrusive aspect of the whole act, along with the violation of norms related to modesty, respect and privacy of an individual about private parts, due to which exhibitionism has been considered as a criminal offense. The urge of the exhibitionist to expose is overpowering and uncontrollable and is perhaps triggered by anxiety, restlessness and sexual arousal. It is perhaps due to the compulsive nature of the urge that the act is repeated, in many cases at the same place and even at the same time of the day. After the act, they may regret and repent it, but in the tension of the moment they may not even care for the legal obstructions. DSM-5 criteria for exhibitionistic disorder. Over a period of at least 6 months, recurrent and intense sexual arousal from the exposure of one's genitals to an unsuspecting person, as manifested by fantasies, urges, or behaviors. B. The individual has acted on these sexual urges with a non-consenting person, or the sexual urges or fantasies cause clinically significant distress or impairment in social, occupational, or other important areas of functioning. Sexual sadism and masochism disorders. Both sadism and masochism are about whether inflicting pain, sadism, on others or suffering pain themselves, masochism. The term sadism is derived from Marquis de Sade's name, who would mete out cruelty for sexual purposes. As per DSM-5, a person is to be diagnosed with sadism if he expresses intense sexually arousing urges and behaviors that involve meting out physical and or psychological pain on another individual. Another closely related pattern to this is bondage and discipline, B and D, that may involve tying up a person, hitting, spanking etc. for sexual pleasures. A number of sexually sadistic acts also occur in a consensual sexual relationship without any evident harm to the partners involved. Thus, it becomes all the more important to distinguish transient or occasional sadomasochistic behaviors from sadism or masochism as a paraphilia. A very small section of males with sexual sadism also enjoy inflicting pain and humiliation acts that are non-consensual and could also be fatal. A sadist may slash a woman's wrist, spank her, tie her up using a harness, and stick her up with a needle to experience orgasm. The act may vary in intensity from one sadist to another. from fantasy to severe disfigurement, damage and even murder in some cases. The diagnosis also includes an important aspect where the victim is to be non-consenting or the one with experience of marked distress and difficulties. In certain cases, sadists are found to mentally replay their torture and harm inflicted on others later while masturbating to attain orgasm. One promising and very important modification that is being worked on is a dimensional approach that could differentiate sexual sadists who are dangerous, like some of the serial killers involved in sadomasochistic tendencies, from those who are not. The term masochism has been derived from the Austrian novelist, Leopold V. Sacher-Masoch. His fictional characters would often indulge in sexual pleasure of pain. According to DSM-5, to be diagnosed with sexual masochism disorder, the person must have experienced recurrent and intense sexually arousing fantasies or behaviors that would involve acts of being beaten, bound or humiliated. However, some forms of masochism can be further worrisome, such as autoerotic asphyxia, that involves self-strangulation. The loss of oxygen to the brain could be resulting on sexual pleasure and orgasm. In some cases, something or the other may go wrong which would result in the individual harming himself by accidentally hanging himself. It may look absurd and even ironic that inflicting or receiving pain could be sexually arousing, but it is not uncommon. Some of these behaviors are also usually mild and harmless. DSM-5 Criteria for sexual sadism disorder. Over a period of at least 6 months, recurrent and intense sexual arousal from the physical or psychological suffering of another person, as manifested by fantasies, urges, or behaviors. B. The individual has acted on these sexual urges with a non-consenting person, or the sexual urges or fantasies cause clinically significant distress or impairment in social, occupational, or other important areas of functioning. DSM-5 Criteria for sexual masochism disorder. Over a period of at least 6 months, recurrent and intense sexual arousal from the act of being humiliated, beaten, bound, or otherwise made to suffer, as manifested by fantasies, urges, or behaviors. B. The fantasies, sexual urges, or behaviors cause clinically significant distress or impairment in social, occupational, or other important areas of functioning. Pedophilic disorder. Pedophilia is also called as pedobephilic disorder, wherein pedes is Greek for child, heb is pubescence and philia means attraction. Thus, it is diagnosed when adults are said to derive sexual pleasure, recurrent, intense and distressing desire and urge, through sexual contact with prepubertal children. DSM-5 requires the offender to be at least 18 years old and at least 5 years older than the child. Most people with the said disorder report to use child pornography to sexually gratify themselves, and thus it has been added in the DSM-5 criteria. Action is not considered necessary for the diagnosis. A person with this disorder is sometimes content with just stroking the child's hair, but may also be found to be fondling with the child's genitalia or encouraging the child to manipulate his/her genitalia. Penetration, although can cause injury but is not the goal, it could be a byproduct of the activity. If not found by adults or protested by the child, such acts may continue for months or even years. Thus, it is considered to be the most tragic sexual deviance. Almost all the individuals with pedophilia are males, and about 2/3 of their victims are young girls, between the ages of 8 and 11. Pedophilia is usually first recognized in the adolescence and then may persist for a lifetime. These child molesters are usually found to engage in various cognitive distortions which are self-justifying in nature, such as, the child will benefit from the sexual contact and that the child often initiates such contact. Some pedophiles have been found to idealize innocence, unconditional love and simplicity, the core aspects of childhood. It has also been discovered the majority of the offenders have themselves been abused as a child. The World Health Organization has defined main types of child abuse as physical abuse, sexual abuse, emotional abuse, and neglect. Child sexual abuse, CSA, has increased over the years not only in India but the world over. The spaces like home, schools, hotel, and other public places have witnessed CSA. The experience has a traumatic effect resulting in changes in the brain, physical and psychological problems like depression, post-traumatic disorder, suicide and such other disorders. The Government of India passed the Protection of Children from Sexual Offences Act, POCSO, in 2012 to effectively address the menace of CSA. POCSO Act was modified in 2019 to include death penalty for aggravated sexual assault, strict punishment to those engaging in crimes against children, levying fines and imprisonment to curb child pornography. To facilitate direct reporting of CSA and timely disposal of cases, the Ministry of Women and Child Development launched POCSO e-Box. DSM-5 Criteria for pedophilic disorder. Over a period of at least 6 months, recurrent, intense sexually arousing fantasies, sexual urges, or behaviors involving sexual activity with a prepubescent child or children, generally age 13 years or younger. B. The individual has acted on these sexual urges, or the sexual urges or fantasies cause marked distress or interpersonal difficulty. C. The individual is at least age 16 years and at least 5 years older than the child or children in criterion. A note, do not include an individual in late adolescence involved in an ongoing sexual relationship with a 12 or 13-year-old. Incest. In 2007, the case of an Austrian incest perpetrator Josef Fritzl shook the entire world. He had kidnapped his daughter Elizabeth when the girl was 18 and had imprisoned her in a soundproof compartment that he had built in the basement of his house. The girl was forced to write a note stating that she had joined a cult and was thus leaving the family. During her long imprisonment, she was repeatedly forced by her father to indulge in sexual activity. She bore 7 of his children, 1 of whom died in infancy. 3 children were reared by the family upstairs and other 3 lived with her in the basement. Owing to one of the child's illness, she went to the hospital and there the staff found Fritzl's story to be suspicious, finally leading to investigation and ending Elizabeth's ordeal. Incest refers to sexual intimacy and relations between close relatives, between whom marriage is forbidden as per the societal norms. These are culturally prohibited sexual relations between brother and sister or a parent and child. One of the most pathological ones being the relationship between father and daughter. Incest is considered as a taboo in almost all the societies, with Egyptian pharaohs being an exception, who would marry their sisters to save royal blood from contamination. According to present scientific knowledge, incest may have a legitimate reason behind it. The offspring from a father-daughter or brother-sister pair will have a greater possibility of inheriting a recessive gene from each parent, which might be a carrier of some disease or disorder. Thus, avoiding mating between close relatives to evade some mental and physical illnesses. As per the evidence, families with cases of incest are usually extremely male-dominated and patriarchal, and the parents are also usually more neglectful and emotionally distant. Treatment. Most of the behaviors involved in paraphilias is considered to be illegal. Thus, someone diagnosed with it is usually imprisoned and then treatment is given to them. How to enhance motivation to change the behavior. Usually people with paraphilias deny having a problem and state that they can control their behavior on their own without any professional assistance. A lot of times the blame is shifted on the victims. Following tips can be followed to enhance their motivation to change. 1. It is important to feel empathetic towards the reluctance of the offender to admit his/her state and seek treatment. 2. Point out how treatment could be of possible help to him/her and its positive consequences. 3. Highlight the negative consequences of refusing the treatment, both legal and personal. 4. Make him/her understand that how psychophysiological assessments will make the sexual tendencies and proclivities very clear. Behavior therapy is mainly directed at altering the associations from arousing to neutral. Covert sensitization is used for it, where short-term pleasure usually outweighs long-term harm because of the strong immediate reinforcement and gratification it is providing. So, the patients are asked to associate sexually arousing images, in imagination, with reasons as to why they are harmful. Cognitive procedures are also used to counter distorted views and modify them. Therapists also use social skill training and sexual impulse training to modify these thinking patterns. Empathy-based training modules are also designed to help the sexual offenders. A popular drug used to treat people with paraphilias is an androgen named cyprotrone acetate. This is like chemical castration, wherein the drug reduces or eliminates the sexual desire by decreasing testosterone levels in the body. Another one that is used is medroxyprogesterone. These drugs are effective only when taken regularly. 5.6 Let us sum up. Now that we have come to the end of this unit, let us list all the major points that we have learnt. Sexuality is considered to be one of the most private aspects of life, which may contribute to love, happiness and pleasure. Sex is considered as a taboo in various societies and cultures, and in many societies, it is talked openly. The human sexual cycles consist of desire phase, arousal phase, plateau phase, orgasm phase and resolution phase. The common sexual dysfunctions in men are delayed ejaculation, erectile dysfunction, and early ejaculation. In females, the sexual dysfunctions are female orgasmic disorder, female sexual interest / arousal disorder, and genitopelvic pain / penetration disorder. Psychological and medical treatment options are available for sexual dysfunctions. Paraphilias are recurrent, intense sexually arousing fantasies, urges and behavior that involve non-human objects, shoes, hair, etc., suffering or humiliation of oneself or partner, children or other non-consenting people. It is to be diagnosed if the condition lasts at least for 6 months. The paraphilic disorders are fetishistic disorder, transvestic disorder, voyeuristic disorder, exhibitionistic disorder, sexual sadism disorder, sexual masochism disorder, and pedophilic disorder. Neurobiological and psychological factors play an important role in the etiology of paraphilias.